All right. Good morning, everyone. Thank you so much for joining and being timely. We're going to go ahead and get started, although some more people might be joining us as we proceed. So we are very excited today to be able to present to you our crisis services training, and BMAP is doing this in partnership with BBHDS. We have Lars Messerschmidt. He is going to be doing most of this talk. We also have Dr. Gregory Stirs, who is a pediatric emergency provider with HCA. So the point of this talk is to go over the temporary detainment, did I get that right? And emergency custody order code in Virginia and how that is applied and what that might look like coming into your emergency department. And also just to help us to think around what that level of care, what the long-term consequences of that might be for people who have had to use that process. So there will be time for questions at the end. If you have any questions while we are going along, we ask that you just drop them in the chat for me, as opposed to interrupting at the time, but we will have time for questions at the end. So at this time, I am going to turn it over to Lars and Dr. Stirs. And if you all want to introduce yourselves, you can do that and then pull up your presentation and take it away.
Good morning. Thank you for that. And thank you for having us with this presentation. Again, my name is Lars Messerschmidt. I'm a regional crisis manager and oversee kind of the emergency services ECO TDO process across the state for Virginia at the department. And I've been here about 3 years. Prior to this, I was at Hanover CSB, providing crisis services on a local government and for the county level. And now I'm at the department. Happy to be here. So thank you again.
My name is Dr. Gregory Stirs. Like you said, I'm a pediatric emergency room doctor. So I'm an acute care pediatrician who takes care of sick and injured children in an emergency setting. I work at Chippenham Hospital in Richmond, Virginia, and I am no stranger unfortunately, to the ECO and TDO process, as specifically as it regards to children. So I'm happy to kind of shed that experience onto this talk. Thank you for having me.
Wonderful. Lars, you should be able to share your screen, and if you can't, let me know.
Can y'all see this?
Yes.
Okay, great. And I also just wanted to, and this might maybe embarrass him, maybe not, but I also wanted to just introduce Kurt Gleason. He is Assistant Commissioner of Crisis Services at the department, and so he was able to join, and I hope that where he can fill in the blanks or add to this discussion as well. So I just wanted to introduce Kurt to the group as well.
Thanks, Lars. I'm happy to be here.
All right, so let's get started. So, well, wait a minute. There we go. All right, so the purpose of the training, the outline, we're going to be touching on these topics, which is kind of our vision of crisis services, kind of on a statewide level, and specifically for the ECO and TDO process. With that, we're going to get into a little bit of history and some contextual information, but we're not going to spend a lot of time on the history of everything of where we are today. Talking about the emergency custody order and temporary detention order process. From here on out, I will most likely just revert to ECO and TDO, but this is what I'm referring to. The commitment hearing process, unintended consequences, of course, some scenarios, and obviously discussion afterwards. The course objective everyone will have an enhanced understanding of the Commonwealth's vision of crisis services, specifically around the ECO and TDO process. the impact of this process has on citizens who are receiving this level of care. So kind of taking the bird's eye view of everything. So this is the vision that we are working towards and implementing for Virginia in terms of our approach to crisis services. Historically, if somebody was in a crisis, everything was kind of jumped to this right here, the CSB emergency services. So somebody calls 911 or they call the CSB if they're familiar with that. And we'll get into CSBs in just one second. Typically, if someone's in a crisis, it was law enforcement and a pre-screener coming to the individual who's in crisis to do an assessment, whether that was in the home, side of the road, emergency department, wherever the crisis was, that's where we went. In an effort to reduce the impact of law enforcement and pre-screeners and kind of that focus of law enforcement first, we're kind of going back and having this no wrong door approach. So really what we have is more of a systematic approach where an individual in crisis can call 988. It can be anybody. It can be the individual themselves, the family member, emergency rooms, whatever the case may be. And from there, the individual will meet and speak with a regional crisis call center clinician. From there, the call center will determine, based on that assessment, the next level of care. So that could be dispatching a mobile crisis response team. This is short term. There's specialized training that mobile crisis responders go through of how to approach an individual in crisis that's in the community. It's about a 40 to 45 hour training that everybody goes through to do this. And really the goal of this service is what do we need to do to keep the individual safe and at home or wherever they are to where they don't need to maybe have to have inpatient hospitalization. Where this is short term, the next would be community stabilization. It's a little bit longer term, up to 7 to 14 days, I believe, and it's still community based. And this is really important. These are all community based services. This is not office based. This is kind of like your ambulance in a sense for the crowd, for the group. This is where somebody's in crisis, you're dispatched to the person and you're de-escalating and problem solving on scene. This is short term. This is a little bit longer term. It's still clinicians going out to individuals' homes or wherever they want to meet to continue with stabilization in the community. There's also the possibility of the 23-hour observation or a crisis receiving center. These are popping up throughout the Commonwealth. We have a handful of them throughout, and there'll be a map here in a second that will help visually see where these are, especially for youth and adolescents. But this is another kind of no wrong door approach where an individual can walk into a crisis receiving center, meet with a clinician, receive an assessment, and from there determine level of care. So whether that's maybe inpatient, or maybe it's community stabilization, or maybe it's a crisis stabilization unit, a CSU, that can happen all here. The individual can stay here up to 23 hours and 59 minutes. So again, it's short term in terms of 23 hours. It's not long term, but it's a great resource and a great service that we're able to provide. The Crisis Intervention Team Assessment Centers, most of y'all are probably familiar with this. These are the folks in your ERs that are sitting with law enforcement, the CTACs. This is the option where if somebody out in the community, if they're ECO'd, they can be brought to the CTAC center for the evaluation to occur. A lot of the CTACs are kind of organically moving over as we're building these CRCs. They're kind of moving over to this crisis receiving center. But there's still going to be, as I'm sure some of you can relate, there's still CTACs in some ERs at this point. Residential crisis stabilization units, or so I mentioned that just a little bit ago. Or also crisis therapeutic homes. These are CTHs. Um, these are crisis spots where individuals with ID or DD can receive treatment. It's sort of the equivalent of a crisis stabilization unit, but the staff is specially trained in working with individuals with an intellectual or developmental disability. CSB Emergency Services, this is one that y'all are probably most familiar with. These are the pre-screeners. Pre-screeners are employed by CSBs. There aren't private providers for the most part. There aren't private providers that are able to be certified pre-screeners. This is another specialized training that pre-screeners go through. And it's really heavily, and that's what we're going to get into a little bit more today, but it's a really in-depth risk assessment. It's looking at capacity, consent for treatment, and if the individual is meeting criteria for psychiatric hospitalization, whether that be voluntary or involuntary. And then here, the REACH program. The REACH program pretty much provides all of what we just talked about, but specifically for individuals with an ID or DD diagnosis. So this is the bird's eye view of the crisis continuum in Virginia, as opposed to where in the past it was straight to law enforcement and the pre-screener. We're looking at some of these, or creating, developing, implementing these other less restrictive options. Because really, when somebody calls a call center, and if it's a mobile crisis responder that goes out, and I can't remember the statistics, but it's a pretty significant number of individuals where the crisis is de-escalated right then and there. They may not need a higher level of care. If they do, we have these other options to look at, as opposed to going straight to hospitalization. So this is the map. This is our map. Obviously, this is showing the CSB, so the Community Services Board. So the department is responsible for, we're authorized by code to operate and provide mental health services, substance abuse services, ID and DD services for citizens in the Commonwealth. A lot of that is done through CSBs. There are a lot of private providers that do this as well, but the CSBs, the community services boards, those are code mandated as well, that local government provides these services for the citizens and of where they live. So, for example, Hanover has one CSB. It covers all of Hanover County. But Mount Rogers is a CSB, but they cover lots of different counties. So it's kind of broken up depending on population and the needs of that area. These regions, 1, 2, 3, 4, and 5, those are health planning districts. How the lines were drawn, I don't really know. That happened a long time ago, but this is kind of how we break up the state in terms of regions and services that are provided in each region. So each county, local government responsible, it's code mandated to provide services for the individuals. Those code mandated services are emergency services, case management, same day access. Anybody can walk into a CSB and begin services. Those are all code mandated services that the county has to provide, typically through a CSB that we have contracts with. There's other providers that do the same thing as well, but for the most part, and the pre-screeners are all coming out of the CSBs. So this is our map. We focused in specifically just for youth crisis sites throughout. We have the same for adults, but for the purposes of this presentation, we just focused on the youth. The orange are the CSUs, the crisis stabilization units. Those are, like I mentioned earlier, they're up to 15 days. The CSU will have a psychiatrist, a nurse, case managers, therapists. Some are locked, some are not. Some accept TDOs, some do not. But really, it's all the same services that they would and treatment that they would receive in a psychiatric inpatient setting, but it's a little bit less restrictive. It's in the community. It really values kind of keeping dignity and respect for the individual that's receiving the service. So do psych hospitals, but I think you get my point. This is more community based. These are the ones that we have established now: Mount Rogers, Western Tidewater, Henrico. We have more that are in. I think I can't see it, but you probably can see it. We also have the CRCs. I think they're in blue. We have more that are being built or proposed to be built throughout the state. But as you can see, there's room for more CSUs and CRCs for youth throughout the Commonwealth. But that is a high priority for our team, and one that we're working on daily. I mean, we've been nonstop looking at areas to create more. So a very brief overview. We're going to get into each of these more specifically as we go, but this is the nuts and bolts of it. You have an ECO. That's an initial hold to evaluate for the potential need for a TDO. There's an 8-hour limit, which sounds like a long time, but it goes by pretty quick. A lot has to happen in that 8 hours. Which would be meeting with the individual, conducting the pre-screen assessment. The pre-screen is about 11 pages. It's pretty detailed. It's a big risk assessment, basically. It also captures capacity and consent, and all sorts of different areas that we're going to be looking at in a minute. But completing that assessment, and if the individual is meeting the criteria, that pre-screen is a legal document. So that's kind of going to be the form that follows the individual throughout the entire crisis process while they're receiving inpatient treatment. If the individual is meeting criteria, then the pre-screener is calling the magistrate and recommending a TDO. It's not ultimately up to the pre-screener. They're assessing, they're making the recommendation. It's ultimately up to the magistrate to issue it or not. The TDO is an involuntary hospitalization to allow for further evaluation. There's a 72-hour time limit, the next business day. So this is basically saying that within, and now for adolescents, it would be 96 hours. For adults, it's 72. A hearing has to occur within that time frame. And then the commitment hearing, that's where the judge determines if commitment criteria is met. One of 3 options can occur at this hearing: either commitment involuntarily, voluntary admission to the hospital for continued stay, or an MOT. We'll get into all this in a little bit, but this is just a brief overview of the civil commitment process in Virginia. So again, this is all the stuff that we just talked about. What's different though for minors are these 2 sections down here. This is based out of the Psychiatric Treatment of Minors Act. And basically what this is saying is that a minor who is 14 or older and objecting to being admitted, a parent can still admit their child who's under 14 or over for a period up to 120 hours. So if the minor is non-objecting and the parent is on board, then this is a route that can be taken. The parent can apply for and consent for admission. An evaluation still needs to occur within 48 hours. That's usually that's through a pre-screener. A minor who objects may be admitted and to be evaluated. In this case, the evaluation needs to occur within 24 hours by the pre-screener. The hearing has to occur within 120. Now the chart, just to kind of visually show the commitment process. You have a crisis, you have the ECO, you have your evaluation, you have your TDO, and then you have your commitment. So backing up a little bit, we've talked a lot about ECOs, and so what is that, or how does that even happen? There are two types of an ECO. There's a paper ECO or a paperless. You don't have to do both. One or the other will work. But for a papered ECO, this is a magistrate must issue the ECO based on the sworn petition of a treating physician, parent, or any responsible person, or on the magistrate's own motion. The ECO is issued, and the magistrate has probable cause to believe the minor meets commitment criteria. And a responsible person can either be a family member, CSB staff, person with custody in detention or shelter, law enforcement, etc. So and then for a paperless ECO, law enforcement, they can take a person into custody and transport the individual to be assessed based on their observation or the reliable reports of others. So really, Virginia does not have a high bar in terms of of the commitment criteria or who can be evaluated. Anybody can go to a magistrate and request an ECO, and based on that information, the magistrate may or may not issue the ECO. That process is in person, typically. I think there are some magistrates or some jurisdictions where maybe they do that over the phone, but most of the time it's in person. The individual walking in is filling out basically a petition requesting an ECO. That too is a legal document, and they're really looking at what's currently happening, recent history, what would happen if the individual did not receive the evaluation, and are they generally meeting that criteria, which is, are they in the near future because of a mental illness, in danger of hurting themselves, harming someone else, or unable to care for themselves or protect themselves from harm due to a mental illness. Law enforcement can do the exact same thing. If they were to go out on a welfare check, or if they're doing a routine traffic stop at a stoplight and somebody is seemingly not doing well, and they feel as though that the person might be meeting criteria or in a mental health crisis, they can take an individual into custody as well. I would say probably 95% or maybe higher of law enforcement have all gone through CIT training. That's crisis intervention training. And that's a 40-hour course that talks about mental health crises, all of what we're talking about with the ECO TDO process. It's pretty in depth, and really the point is for law enforcement to kind of at times be wearing their social work hat when they're out in the community, or if they are responding to a person in crisis, to be looking at it through a lens of somebody's in a mental health crisis, not through a criminal type lens. Kurt, you have your hand up.
Yeah, thanks, Lars. You said something that popped in my mind. So, hi, everybody. I like Lars, before this work, I was a pre-screener, worked for Region 10 Community Services Board, and something that came up often in my collaboration with the emergency room physicians at UVA Hospital was that what Lars was saying around magistrates sometimes will take testimony over the phone. And what I've learned is, in terms of issuing a paper ECO, what I learned about that is they would do it, but ultimately the liability in that instance, like if I call the magistrate up and they don't see me either on a Polycom, which is the technology that's governed by the code, strangely enough, or in person, then they can't swear me in, and they can't take legal testimony from me, from anyone, to then determine if that testimony finds probable cause. So what I'm saying is, if they just took testimony over the phone, it's hearsay. And then ultimately, if they issued an ECO, it would be on their own motion. And that would be the magistrate saying that they think that person is at risk, not that they received lawful testimony of someone sworn under oath. And so that I think there have been times where magistrates are like, all right, doctor, feel free to call me. I know who you are. I know your voice. I'll be willing to issue on my own motion from a conversation with you. And I think magistrates more in the recent past have been more hesitant to do that. And while it's cumbersome, it's understandable because ultimately the liability is on the magistrate saying that they are issuing on their motion as opposed to the sworn testimony of a responsible person, which is kind of a subtle but yet a really important thing. Is just one more instance of how this is as much or more a legal process than it is a clinical one. So for what it's worth, that testimony over the phone thing often would come up in conversations with physicians. And so it seemed like it was worth going back to briefly here. So thanks for that interruption, Lars.
Yeah, it's a great point, and one that it's all the nuances, right? And so that's where for pre-screeners, it's an interesting position to be in because there's a clinical component. There's that's often driven in a sense by a legal requirement, and then so there's all these different kind of like we're often looked at it as we were kind of the hub and you had all these different spokes. And so part of the spoke is legal. If you're in the ER, the other spoke would be ER staff and physicians. You've got the family, you have the individual in crisis. And so it's all kind of merging into one. And again, where it sounds like it's 8 hours to come up with this decision, the decision might not take 8 hours, but the process of then finding the bed and going through all of the other legal aspects is what takes up a pretty good chunk of time. So, but this is the beginning of the initiation of the ECO. So that's issued. The execution is the actual, so if it's a papered ECO, the magistrate issued it, the magistrate will print it off basically, and then call law enforcement and say, I have an ECO, I need for you to come pick it up and execute the ECO with the individual in crisis. So how that happens is dependent on jurisdiction and law enforcement agency. It could be that one deputy goes to the magistrate's office and picks it up and delivers it to another deputy who's going to then execute it. There's a host of different ways that happens, but basically if there's a paper, law enforcement has to have that paper in hand to then lawfully take the person into custody to begin this process of assessment to determine if hospitalization is necessary. Once that ECO has been executed and they're in law enforcement custody, that also means handcuffs. I mean, they're in law enforcement custody. So as much as we like to try and avoid that, and that is law enforcement standards of operation. That's their call of somebody being in restraints. So as much as we would like to not have youth and handcuffs, or really anybody, but seeing a young person in handcuffs or somebody in their 80s in handcuffs is always difficult. It is for anybody, but it just seems like it's just when you have a 8-year-old in handcuffs, it's pretty bad. So we take all of this. We don't take any of this lightly. And that's why we have this process that we go through to avoid those circumstances. These are all the codes that you can reference if you'd like to, that are specific to child and adolescents. But as soon as law enforcement, once they get that ECO, then they have to notify the CSB to let them know that they have somebody in custody to do the evaluation. Really, law enforcement, they determine where that evaluation is going to occur. Most of the time now, they're going to be in CTACs, which are going to be in y'all's ERs. Some are moving out to the CRCs, but for the most part, most of them are going to be in your ERs. And there's medical ECOs or TDOs rather. I won't get, but y'all probably know more about that than I do because you're the ones that have to call the magistrate to request a medical TDO. But the ECO, it's also there's a med clearance piece that has to occur. That's, I think, why initially a lot of the CTACs were thought to go to the ERs, because you have to rule out a medical component if there's a medical piece that's causing this increase in psychiatric symptoms, like a UTI, for example. So there is a medical component as well for medical clearance, which I'm sure all of y'all are very familiar with. So the pre-screen, we conduct this in person. We do have the option of doing it like telehealth or through that. We used a lot of that during COVID. But for the most part, they're all in person, face-to-face, determining if TDO criteria is met. If it is, then we need to find a willing facility that will accept. If we get to the 8 hours and nobody has accepted, there is a new law, bid of last resort. This stemmed from the tragic incident with Senator Creed-Deed's son, where there was not a private facility that was able to accept, whether they were full or because of the circumstance, which is another piece. You know, the private hospitals, they have that ability, depending on situation, to accept or deny. So even if a facility has open beds, they are still able to deny based on various circumstances or reasons, exclusionary criteria or acuity or milieu, or whether they're full, whatever the case may be. So because of that, tragic incident occurred where the senator's son attacked the senator and then ultimately died by suicide. So then there was a law of bid of last resort, which is basically saying if a private facility, if you can't find a private facility, then the state hospital, which is through us, must accept. And then additional or optional alternative facility search. So if a minor is detained in a state facility, the facility and the CSB may continue to search for an alternative for 4 hours. So let's say this happened and the youth ended up at Commonwealth. The CSB and the facility can still continue to do a bed search looking for a private facility that is willing to accept and able to accept, and a transfer can then occur at that time. So I threw this in here just to kind of give a little peek behind the curtains. There's a lot of work that goes into the evaluation process, and each clinician or CSB may do it a little bit differently. But all of these areas are getting assessed or looked at. So, and some of this is mandated by code. So contacting family or collateral contacts, this is going to be, if you have somebody who's just refusing to participate or to speak, whether it's for whatever that reason is, ES, emergency services, the pre-screeners have the ability to contact family or collateral contacts to understand the manifestation of the mental illness, the crisis, what the behaviors have been like for the past day or two, what could potentially, how's it going to look if the individual is not receiving treatment? What is it going to look like when they get back home? So all of that to kind of form the disposition at the end. Looking at intake or triage notes, so if then the ER looking at nurses' notes, doctors' notes, law enforcement looking at their report, hospital staff report, CSB staff and records, so if the individual is receiving treatment at the CSB, being able to have contact collaterally with their clinician to see how behaviors have been for the past couple of days, or if this is a increase in baseline behaviors or not, other medical reports and records. So all of this is good information that pre-screeners are looking at and assessing when coming up with their disposition, all this collateral information. And this obviously can take a little bit of time too, as you can imagine, especially if this is the first psychotic break for for an individual and talking with family, or maybe it's not, and this is, just getting those nuggets of information to help form your disposition. And the family's in crisis too. So a lot of times, it's spending time with the family and helping them through this as well. So the issuance of a TDO. So you've done all that. You determine person is meeting criteria for TDO, which is basically the same as the criteria for the ECO because of a mental illness. In the near future, there's a high likelihood that the individual will harm themselves, harm someone else, or unable to care for themselves or protect themselves from harm due to a mental illness. That third prong, and I will not get on my little soapbox, but that's the one that's always forgotten because oftentimes, and y'all can probably relate to this a little bit easier, but the person doesn't have to be suicidal or homicidal. They're, somebody who's psychotic, they may not be suicidal or homicidal, but they can't protect themselves from harm. They're not able to, their symptoms are leading them down the path of paranoid with the medicines that they should be taking, so they stop taking it, all of that. And so that's very much a pretty critical third prong as well. So you can still need a high level of care, even if you're not suicidal or homicidal, but you're unable to care for yourself due to a mental illness. So you've determined all this. It's a sworn petition. So as a pre-screener, you would go to the magistrate, present your case, recommend the TDO. Magistrate will either issue it or not. Most of the time, the magistrate will issue it. We've got really good relationships with the magistrates, but it's still up to them. The magistrate's going to take into consideration the recommendations or of the physicians or psychologists, the past action of the minor, past mental health treatment, relevant hearsay evidence, medical records, affidavits. These are all the things that the magistrate's also going to take into consideration on top of the pre-screener's recommendation after having done that evaluation and ruling out all less restrictive options. So once the TDO has been issued, so the TDO has been issued, the individual is taken, let's just say in this case, from your ER to then the accepting facility. The period of temporary detention must not be longer than 96 hours. So within that 96 hours, a hearing needs to occur. The period must be sufficiently long to allow for these three things to happen. An independent evaluation. So prior to the hearing, the judge or special justice must require an independent evaluation prior to the hearing. This is somebody not employed at the CSB, typically not associated with the hospital or the accepting facility. It's an independent evaluator who's at the end going to make their disposition of recommending commitment or not. They're also looking at the pre-screen report. This is what the ES has completed during the TDO period. The pre-admission screening report must be prepared. The report must be provided to the court before the hearing. Then it's admitted into evidence. And the duration of the TDO should be sufficient to allow starting treatment to stabilize the person to avoid involuntary commitment if possible. So there's 96 hours once they're at the facility. These things are happening, but it's also the facility's responsibility to start treatment to try to avoid involuntary commitment to the facility if possible. One thing in here, which is a relatively new thing, is that the judge or facility director may release a minor to the parent prior to the hearing if the minor does not appear to meet commitment criteria. So what this is saying is they're at the facility, or maybe they're in their ER and they're waiting for an accepting facility. You're getting close to time for a bedside hearing. If the youth has stabilized and maybe it was just, a situational situational depression or emotional deregulation occurred. And so after they've had some time, after they've gone through the process, everything is kind of de-escalated and they've returned to baseline. The facility director, or if they're at the facility, these folks can release the minor. Now, it's not as simple as that. There's going to be involvement with the staff psychiatrist or psychologist to do an evaluation. ES is going to be most likely brought back in to do a reevaluation to determine if the individual is no longer meeting criteria. And everybody needs to be on the same board. Everybody needs to, this is consensus that the individual no longer meets that criteria. And once that occurs, then it's up to the facility director who is able to release the minor prior to the hearing. Inpatient admission. So again, this is kind of referencing this. So this is with that Minors Act that occurred. So really, this is, again, it's saying that a minor who's 14 or older and objecting to admission can still be admitted by a parent for a period of time. This is for this up to 120 hours. An evaluation still needs to occur during that time within the 24 hours. Right here, minor must be evaluated within 24 hours. That's with a pre-screener. If the pre-screener determines, yes, the individual is meeting criteria, then that's when the facility must file a petition for the hearing. And a commitment hearing may be scheduled based on a TDO or based on a petition for a hearing, independent of the ECS. So this is the situation where family brings their child to a psychiatric hospital. They're requesting admission. The facility admits. The assessment still needs to occur if it seems that at the end of the disposition, if criteria is met for inpatient, then the hearing needs to be occurring. So again, kind of like at the beginning prior to the hearing is scheduled, a lawyer is appointed. So every hearing, there's a lawyer appointed unless the family has their own lawyer. Of course, then that person can represent and be present at the hearing. Notice to the minor, parents, lawyer, guardian ad litem, and J&DR court. They're all notified of the hearing. The court orders clinical evaluation. This is arranged by the CSB. The CSB submits the pre-screen report. The hearing may be continued once for up to 96 hours. So again, once they're out of your ER, there's still quite a bit that's happening for the individual prior to their hearing and leading up to the hearing. It's up to the judge, depending on, I've never really been in a situation where a judge has not allowed a family member, especially for a youth, to be present during that hearing, but it is ultimately up to the judge or the special justice who conducts the hearing for that. There is a guardian ad litem that is appointed. The reason for that is just it's an added voice for the child, making sure that the needs and well-being are considered during the hearing process. That, and if the youth's parent also suffers from a mental illness and may not be doing well, it's just an added advocacy for the youth during times when that may occur. So before any hearing, this is true for adults, but for minors 14 and older, at the beginning of the hearing, the court must inform the minor that the minor can apply for voluntary admission. The minor's parents must also consent for the voluntary admission. So you could have a youth that says, no, I don't want to be here. The parent says, yes, I think you do need to be here. The hearing's going to occur. You could have a youth that would say, yeah, I want to be here. parents may say, no, I don't want you to be here. You don't need to be here. A hearing's going to occur. So there needs to be consensus on this part for the judge to determine if voluntary admission is warranted or not. So what this chart is really just saying is kind of recapping everything that we just talked about. It's kind of a little bit, I guess, of a decision tree, but if the outcome is commitment, if the parents approve it, then the order for inpatient is entered. If the parents do not approve it, the court may not enter order for inpatient treatment, and the minor is released to the parents. That's the judge's decision based on all those things we just talked about. But if the judge feels differently, then they're moving forward with the hearing. It's necessary to protect is it necessary to protect the minor's life, health, and safety or development? Is that we could have a hearing because of that and rule that yes, commitment is warranted. And is the minor meeting the commitment criteria? And the order for inpatient is approved. Mandatory outpatient. I will not get in the weeds with this because there are many weeds with this, but basically this is also an option in terms of it's a form of court-ordered treatment. It's conducted on an outpatient basis. It's not inpatient. And there's a MOT treatment plan, which is pretty robust. That's usually developed with the CSB or the provider who's going to be providing the MOT treatment. It has to go through the courts. The courts are very much involved in this, and the judge needs to agree to it. The MOT may include day treatment in the hospital, night treatment, other appropriate treatment that meets the needs of the person, but it must not include restraints or physical force and provision of medication. Some areas use this heavily, and some areas do not. So there is a lot of focus on this currently. It kind of comes in waves. None of this would really be determined with y'all in the ER. This is usually something that's looked at afterwards, but it is an option as an outcome for commitment. Unintended consequences. So there are many. These are the some of them though. The person is in handcuffs for the duration of the whole ECO TDO process. So that's certainly an unintended consequence. The involuntary admission will remain present on the medical record. Could be potentially a difficult hearing process, can certainly be traumatic. Prolonged ER wait times, which I know all of y'all can experience and relate to. And this is, we're taking away somebody's civil liberties during this process. So, which is why kind of going up to the beginning of the slide with the kind of the little bubbles, we're really working. We've always had those options, but typically, historically, the way the process or the system is that if somebody was in crisis, law enforcement and pre-screen. Now we've always had those other options, but maybe not so much in an organized fashion, maybe, or a place where 988 was in existence. So really that's the key piece. And 911 and 988, they have integration with each other. So if somebody if a family member calls 911, dispatchers are trained in understanding kind of the mental health calls, and they're familiar with 988. And so there can be a direct link from 911 to 988 to kind of look at speaking with somebody at a call center and determining from there what's the next level of care that makes good clinical sense and sense for the individual that's in crisis. Yeah. So we're at the cases. Are there, I know that the request was to put questions in the comments, but we kind of unpacked a lot. Are there any questions or thoughts or areas that we want to go over again, or specific to what's happening in the ER, um, for you?
Yeah, if you have questions, please feel free to unmute yourself and ask your questions now before we move into the next piece of this.
Yeah, so Lars, I had a question. So you have that slide with all the spokes of kind of things that the crisis interviewer is going over. Can you give us, like, from our perspective, I think we're pretty focused on the clinical aspect of the patient's presentation. Can you give us a little insight as how you balance the legal needs, the clinical needs, and then the parental needs in a patient that you're approaching?
Yeah, it's a good question. So it's all a balancing act. So all of that is what's kind of going into our our process with the disposition. I can't say that there's any one area that would weigh more than the other. I mean, we're certainly looking at the medical piece. Um, we always try to have a really good relationship with the ER doctors, because that's where we're going to be getting the information medically. We're not medical people. And so understanding if, I mean, a UTI is the best example I can give. Somebody who comes in, they may look psychotic, but after you and the nurses and the labs come back and it's determined that it's a UTI, we are most likely not going to recommend a TDO in that circumstance. There's a medical component that needs to be addressed, and typically once the medicines, or whatever the treatment is for that medical piece, the person will most likely then clear up and return to baseline. The other question, but then to kind of follow that strain, the question that we would then be asking the family is, has this ever happened before? Has the individual, somebody in their 40s who all of a sudden becomes psychotic? That would be unusual. Usually the first break is in their 20s. So somebody who's in their 40s who's having their first break, um, certainly want to look into that. But is there a medical reason for that? Why did that happen all of a sudden in their 40s? The code, the legal aspect, is kind of dictating that we look at all of those areas, that we communicate with hospital staff, understand from a medical perspective. We're not doctors. What's the doctor saying as to potentially what's causing this? Or no, they're medically cleared. There's nothing medically happening that would cause this increase in symptoms, and this seems all psychiatric to me. So then we would kind of go down that path. Same with the family when speaking with them. With adolescents, it could be that they wanted something, and I mean, not to minimize, but it could be that they wanted something or something didn't go their way. They heard no, they're not used to hearing no. And because of that, then this big deregulation of emotions came out. They're threatening to harm themselves. They gesture that they're going to. And is that a pattern? Every time that happens, this is what happens? Or did something really significant occur that's out of the norm, and that the behavior that was displayed is away from their baseline? But then looking at the collateral, for clinical records, have they been diagnosed with something? And it's tricky with youth sometimes, because everything is so new, like sometimes you don't really have a pattern of baseline to really base the decision on what's happened in the past, because it could be all very new and the parents are just as kind of flabbergasted as well. And so it's just putting all those pieces together, and asking those questions. And the pre-screen is helpful in a sense of the guide, because it really digs into, it's not just asking, is the person suicidal? It's encouraging, and a lot of pre-screeners have additional training with assessing suicide risk or homicidal risk. It's really digging into then, all right, well, what's your plan? What's the intent? what's your desire in doing this? If you're some of the questions that would be asked of like on a scale of 1 to 10, where are you right now with following through? What would make it lower? What would make it higher? What triggered some of this? Is it relationship with the parents? Is it something that happened at school? Is it something that happened with a friend? So, and all of that is coming into like if there's terrible parent-child relationship and sending them back home, could you could be all meeting again in the next couple of hours. So then looking at, was there another family member that they can spend the night with, or is there a safety plan that we can implement to avoid this? Is the psychiatric hospitalization going to benefit the individual? So it's taking all of that into consideration, and I can't really say that one outweighs the other. It's all very much this accumulation of information. And then I think as us for pre-screeners with the clinical background and the training, basing all of that on clinically, what's the most appropriate next step? If it was it a change in medicine, and that's what caused the increase, and so they need a safe place to, and in the meantime, because of the medicine change, they're really at risk. There's no safety plan. They don't have capacity. They're not able to consent for voluntary treatment. It's going to be really dangerous if they go back to the community, or maybe community stabilization, the community is not appropriate. All of that's going to come into consideration as well. Kurt, did you want to add something too?
Yeah, and just to sort of underscore some of the things Lars was saying, I think it's, well, two points. I mean, one, the pre-screening is a legal assessment, not a clinical one. I mean, obviously it has important clinical components, but I think it's important to note that we're answering a fundamentally different question. Like, it's a very, very much related question, but a fundamentally different question, right? The treatment team at the ER is determining what the treatment needs are for the individual. Should they stay? Should they get treatment here? And what the pre-screener is answering is, can I force them? Or in other words, can they go? Right? And oftentimes the answers to those two questions will be the same, but not every time. And so the reason the pre-screener is looking at all that other information is determine, is there a way to mitigate any identified risk somewhere else than here, right? So it's not just what's the presentation and will they benefit from treatment? It's, is there some other way that they can mitigate the risk? And if so, even though I might want them to stay, I can't legally restrict their rights, right? And I mean, Dr. Sturr, someone in your question, you know, the wants and needs of the family are relevant too. So kids are obviously much more complicated than adults in every single way when you get into law and treatment. But it ultimately comes down to, can I, within the bounds of the law, take away this young person's rights, right? Not what is going to be the best thing for them. And so that's why all that external information is really relevant to that legal assessment to determine, can I restrict their rights, or can I petition the magistrate to restrict their rights?
What other questions or areas for review? Okay. Well, let's jump into, there's 3K. I don't know where we are on time, so I'm not quite sure what time we have remaining.
We have until noon and it's 11:34, so about 26 minutes.
Well, why don't we just do, I mean, we can go through these pretty quickly, or we can just do one, because I certainly want Dr. Sturz to have his time as well. Should we skip the scenarios or do one? And let's do one.
Yeah, let's do it at least.
Okay. All right. I won't read this out to y'all. Y'all can read.
So I think with this case, it's a 14-year-old who I'm trying to remember it real quickly. but the point of this case was that the age of consent in Virginia is 14. Children and children under 14 have their medical decisions can be made by their parents. So even though she has no evidence of impaired capacity, therefore we really had to respect her autonomy. One of the problems we run into in the emergency room is that, you know, parents want one thing, and which may or may not be in the best interest of the child. And children often want a different thing. And so kind of reconciling those different, you know, desires and rights can be difficult from us from a medical legal standpoint.
When I was reading this, it took me back to a lot of the situations of doing the evaluations, and all of this sounds very, very familiar. And this kind of goes back to what Kurt was mentioning just a minute ago of looking at all of those sources of information, and legally, can we take away, in this case, her right, despite what she wants or does not want.
So to clarify, it's under 14, they don't have autonomy, but 14 plus they do. Yeah.
This one, when I look at it, is I mean, obviously so much would depend, but it's this could be one of the more frustrating types of cases, right? Where based on what's here, I would think the pre-screener is likely to agree with the treatment team that inpatient admission isn't indicated, and would likely try to drive that way. And then what happens if parents say, well, we're not taking her home? Then, you know, when I said before, if you accept the sort of conceptualization of a Venn diagram of commitment criteria and treatment needs, there's a lot of overlap. Often the things on the fringes is going to be where the treatment team may want to keep someone, but the pre-screener doesn't find evidence to compel them. But there are some cases where it's actually on the other side of that Venn diagram, where no one really thinks the person needs to be admitted, but the pre-screener can't get away from commitment criteria. And this might be one of those where mom and dad say, well, we hear what you're saying, but we're not taking her home. She's unsafe. And may ultimately be that there's no other disposition in the moment. Maybe that's a CPS referral. Maybe there's some other activity that has to happen. But I could see this, you know, depending on how it would play out, I could see this one manifesting where there's no way out of an involuntary admission. But that
I wrote these cases from real experience. So
yeah.
Well, and the other added tricky part is that this sounds like she's voluntary, but if this was all happening and she was under ECO, yes, you might call CPS, but you're not going to get any resolution from CPS in the 8 hours at all. And so this is kind of where a pre-screener may be backed into a corner to a degree, because those other options that I mentioned earlier, mobile crisis, community stay, those are all voluntary services. And so even though she may say, yeah, I want that and I can do it, the call center is still going to need to get the consent from the parent to come to the parent's home to provide the service after hours or whenever the case may be. So if the parent says no, and I don't want anybody coming to my home, and that's not going to happen, and there's no other safety plan that can be arranged, it is a tricky spot to be in.
So the child has consent at the age of 14 and says, I can do community stabilization or these other services, but the parents say, I don't want anybody in my home, but the child has consented to these services, then what happens?
It's tricky. It's tricky because the law will recognize that they have the ability to consent for that, but they're still on the bigger realm, they're still minors because they're under 18. So that's where then it becomes tricky with then, like, for example, community stabilization. Um, it's still somebody coming to the person's home, and the adult can say no. Or she's manipulating you, all of you. I know my child better than you. We've gone through this so many times. She's going to say what she needs to say. She's going to look innocent. She's going to get home. The minute we get home and we say, no, you can't go to the movies, we're going to be right back to where we're going to be right back where we started. And for me at least, that's a key piece of information. Like, what is it going to look like back when we would do crises like in the home, like with law enforcement before we kind of moved into the ERs. But for this, I mean, I would just ask the family member, yeah, everybody kind of gets on their better behavior when law enforcement's in the room. What is it going to look like when we all leave? What's the rest of the night going to look like once everybody's left, that this dust has somewhat settled? What is it going to look like at 10 o'clock tonight when this situation comes up again? Because it will. And if they say we're going to be right back where we are, or they're going to up the ante, and instead of they're going to actually cut themselves because that's what they've done in the past. All of that is information that I would take into consideration, outside of the singular crisis in the moment right now, really looking at past and potential future behaviors that would help shape my disposition.
Yeah, this one seems less about the risk assessment of the child and engaging with the family system to find the best dispo, right? Because again, she could agree to those services, but they're not going to be effective if the family isn't engaged. And so then, which is where we ultimately have to get. And you would sure hope that a short inpatient stay isn't needed to get from A to B. And so hopefully the pre-screener, hospital staff, other providers can engage with the family there in the moment and help them understand there's a better path with a better outcome.
To add to your point there, like, I'm not sure in this case a hospitalization is going to make this person better, right?
No.
Like, yeah. So that's
No,
the other,
likely to make them worse, right? Like
Right.
it's now a risk factor that follows them forever,
Yeah.
right? And yeah, that's right. I think in this one it's pretty straightforward that the pre-screener and the treating team would be in alignment. It's just, would they be able to manage the family system to get to the best outcome for the child?
Certainly underscores the biopsychosocial model of mental health.
Right. And it could, create a platform for then the parents of using this tool in the future. Sometimes I think parents, at least in my experience, they would say, well, they need to learn a lesson. This isn't how you act. And a TDO is not, we're not here to help teach lessons for behavior. So we have a couple more. I mean, these are always good. But again, I'm anxious with your time, Dr. Sturz. I don't want to take away from your time either.
I blocked this time. We're fine. I've got the iPad babysitting, so.
Okay.
Yeah, I think, yeah.
Do we want to?
Yeah, case number 2's.
Okay.
So this one is an adult. She took an ingestion of Benadryl. So she took 7 of them. No evidence of co-ingestion. She's asymptomatic at this time. We did a big medical workup and it was all negative. And she becomes medically cleared. At that point, we moved to the kind of behavioral health assessment portion of her stay in the ER, where she becomes non-compliant. She doesn't want to be admitted. She becomes more and more agitated, and to the point where she's combative. She's not safe to herself or to my staff in the emergency room, and she has to get a what we call a PRN medicine, which is an as needed to control her to kind of abort those dangerous behaviors. So an antipsychotic like ziprasidone. And at this point, we're just trying to maintain her safety and the safety of staff. So we wrote this one to kind of illustrate how a semi-voluntary patient can go from voluntary to involuntary at any time. But the point at which she becomes combative, and I am giving her essentially what is chemical restraints, we need to move to petition the CSB to obtain an ECO or a TDO. Do y'all have any thoughts on kind of how that progression can occur and how cases can go from voluntary to involuntary or back to voluntary at any point in this process?
And to add on to that question, would you go to the ECO process or straight to the TDO process, or what? Yeah, how does that work?
I think that one's a question for the facility. I'm sorry, Lars, but I think that's a question for the facility, not for the pre-screener, right? Like, I think each facility would have their own process and local process with the CSB, but being under evaluation for TDO is not in itself it does not make the person involuntary, right? Like, I think well, at least at UVA hospital, the security team would, in good faith, maintain the person's custody during the time of the evaluation and not petition for an ECO. Although if the person exhibits certain behaviors, they might, for liability risk, then go to petition. But we would often say, like, we'll come and evaluate, or you request an evaluation, we do it. But just want to be clear that our evaluation we're not able to hold the person, right? The ECO is the tool to hold them. And so I think there's many ways to sort of solve that question, but it's a good question that doesn't necessarily fall to the pre-screener. It's more about the facility's standard operating procedures in this instance. I don't know, Lars, would you say that differently?
No. Mm-mm. Yeah, I mean, if there's a request in the ER for this, I think Dr. Sears, you're with HCA, so I feel like ARC would probably be your internal group of clinicians that would do that assessment, maybe. And if they then felt as though that the person may meet criteria for TDO, we would then most likely, crisis would then get the call from the ARC team of, this is what we've done, we've ruled all these things out, we're not able to, blah, blah, blah. And so then RBHA would then most likely come and do the assessment to determine if criteria is met. The other, where it gets tricky sometimes, is if somebody, let's say they come in voluntarily and then it's a voluntary admission to the unit, and then after a couple hours they're like, no, I don't want to be here anymore, I want to leave AMA. That's where we will most likely, crisis will get a lot of requests to do the evaluation. And depending on relationship, board, jurisdiction, just all of those things, some boards in the hospital, the unit will have the agreement of, well, in those cases, the new unit just need to petition for an ECO, and then we'll come. Other boards will say, sure, we'll show up and we'll do the evaluation. So again, kind of like what Kurt was saying, a lot of it is dependent on the facility. They have the ability to request that ECO as well. But in the ER, yeah.
I think on this case, it's go back to my Venn diagram conceptualization, it's kind of the opposite side, right? Like, I think reading this, it's pretty clear that an inpatient admission could likely benefit the young woman, but the pre-screener would have to determine, is there enough evidence to suggest that if she leaves, she's going to be at immediate risk? Like, it's clear that she has a ton of risks, and it's clear that there's much to work through. What they are, we don't know, but there's something to work through. Something brought her here. The pre-screener would have to determine, if she leaves, is she likely to overdose again or have some other kind of harm to herself in the next 48, 72 hours? And I don't know, my experience, many times this person would meet TDO and many times they wouldn't, even though everyone would agree inpatient admission would be good, would be helpful to sort of for a number of reasons.
What is there a particular piece of data that you would look at to make that, or it's just a gestalt?
No, I think this is where it gets where I was saying before, it's a legal assessment versus clinical, and bringing in all that information to look at all of the, the history patterns, access to medications, family histories, like who knows what kind of information would tip the balance, but you got to get all of that external information to have a complex conceptualization of her. But really the question is there immediate risk, right? And immediate meaning 48, 72 hours, not beyond that, because as we know, so much can change in a short amount of time, right? So her behavior in the ED would be very important information. So we'd have to, if there was to move to release, whatever information would have to overcome the fact that her presentation and behavior is such that it is. But mom got rid of all the pills and there's nothing left, and they agree to watch her, and I don't know, I'm just going to start making things up, but there's all kinds of things that we would have to look at to draw as straight a line as we can from how she is now to some risk in the next 2 or 3 days. And if there isn't clear evidence of that, or if there's enough protective factors that outweigh that risk, you can't restrict rights, right? More often than not, I think this would result in an admission, but I just say it's one of those where we may all agree it's the best thing, but if there is enough protective factors or an alternative possibility or something that suggests that there's no immediate risk, it may be that she goes home.
I think it's interesting from my perspective, just to be like, yeah, this girl would benefit from an admission. She needs to be admitted. There's to one of the things that I'm learning, I think, is that there's a lot more that goes into that decision, that that as ER physicians we're not privy to all the time, or have the time to understand all of that.
Well, and Lars, I'm sorry, I know you're about to say something, but I referenced my time at UVA, which was interesting because most of the time we were working with residents, right? And so that's a different sort of dynamic. And so once I realized anyway. But what I would say to them often is like, look, my presence unburdens you of worrying about the legal code. All you got to do is determine what's best for her. Right? Like they're like, she should stay. I'm like, I understand that. But so like, take me as a gift. I'm unburdening you of having to know what the legal code is and whether or not her rights can be taken away. You don't have to worry about that. Just what's the best course of care. Then my job is to determine whether or not she can be forced to receive that. Right. And most often it's going to be, I think often it's the same answer, but not always. And that's in Virginia, at least, that role and responsibilities placed on the pre-screeners, not the treating physician.
Thank you.
Yeah, that's the part I was actually just going to bring up, Kurt, is that it's the pre-screener who's kind of liable at the end of this. And so you never know where these situations can end up. And before you know it, 8 months later, you're before a judge because there's a case brought before you that you held somebody against their will illegally, or that they then left and then did harm themselves and you didn't do a proper assessment. And so there is that, not that that's what's driving the decision making. So I don't want you to leave thinking that, but there is that kind of hanging in the back of every pre-screener's head of the legal responsibility of what may or may not happen dependent on the disposition. And when it's really gray or not clean, the situation, especially with minors, with family dynamics and everything, I mean, really every clinician, I'd always tell the folks, you know, it's really going to make me nervous if I never hear from you while you're out on a call. Like if you're not calling me or calling back to the office of some sort of case consult or running the case by, and I kind of know a little bit about what's happening of what got you out there and I never hear from you, that's going to make me really nervous. And I'm probably going to start peppering you with questions, despite whether you've been doing this for a year or 25 years, you know, like you never really want a pre-screener to feel like they're out on the limb by themselves. And so really just that collaboration, because the other thing that comes into consideration, if the case were to go to court, the court is looking at kind of what was prudent in this situation. What would any other pre-screener in the same situation do? And if 8 pre-screeners say, I would have TDO'd and this pre-screener did not, the court's going to look at that of, did that clinician act in a prudent manner?
Yeah, and Lars, you said something I think that's important for the ED physicians to know. I mean, it's standard practice for CSB, best practice, and it's actually required for a period of time when there's a new pre-screener, but standard practice for all pre-screeners to consult with a shift supervisor on any release. So any time that we're not TDOing, like he says, there's a case consultation. And I'll say, like, I did the work for 10 years. I think I got pretty decent at it. But even at the, you know, in year 10, if I was doing a shift as the director of the program and was moving to a release, I would call a colleague and staff it, just because it's, you know, there's always going to be 2 or 3 voices. And there are many times where I would call and be like, I think it's a release. And my colleague would say, nope, I don't hear it, Kurt. This is a TDO, or vice versa. Right. So it's, that process is fairly rigorous and grounded in consultation and you know, sound practice, because like Lars says, the liability falls back on that, in that risk assessment.
This last case, I think, was a case of a 17-year-old with a history of autism. He's had some increased aggression at home, or at his group home, and his aggression and hitting staff, refusing to take his medicines. He's uncooperative and upset. The pre-screening was done, I guess, in the community, and a bed search is started in the ED. We restart his home meds. He becomes calm, cooperative. And I guess the question was, do we still need a TDO, or can we consider a least restrictive method once before the 72-hour mark has been, or I guess 96 now in this case? Has the crisis been resolved?
So for this one, it's REACH, that program I mentioned at the top. We would really want REACH to be involved and kind of do a co-assessment with ES for any individual with ID or DD, and especially in this case. So he came in on the ECO. It looks like they're going towards the path of a TDO if they're doing a bed search. So this is the one where there is that caveat mentioned earlier, that if the TDO has been executed and still waiting for that commitment hearing, or they're in your ER and it's about to be a bed-to-bed, or not a bed-to-bed, but a bedside hearing, if after consultation, and there's a safety plan in this case with the group home involved and guardian, if there is a guardian, if everybody's in agreement that the person may no longer meet that criteria, the facility director, the ER of that facility, can release the individual prior to the hearing. But everybody needs to be on that same page. And I would recommend a pretty comprehensive safety plan that would go into it as well. So to answer the question, does the patient still need a TDO? Maybe, or maybe not, if everybody's still in agreement or is in agreement of one of those 2 options.
And to go back to the liability point, if a patient, adult or child, is released at hearing, then it's the special justice who makes that call, right? But in an instance where the facility director releases, legally that falls on the facility director. Like Lars says, you want to have good consultation with all the people involved, but it's ultimately the facility director saying this young man no longer meets commitment criteria, right? And so sometimes when you get to that hour, I mean, it's facility to facility, but I've seen some say, well, let's just get to the hearing because I don't want to be the one on the paper that says he's good to go, right? But on a different instance, if you're halfway through the TDO or 2/3 of the way through the TDO and it's crystal clear that the crisis has been resolved, the code does allow a pathway to release them prior to the hearing. It's just who wants to hold the risk on that.
Typically, I think in those circumstances, the facility director is this isn't a routine thing, so it's usually going to then also involve the healthcare organization's risk management and potential lawyers involved in that as well. So it's still the code does allow it, but on the facility side, I suspect that there would probably be a lot of consultation with risk management as well.
And on that note, thank you so much. This has been very informative. These cases were great. I learned some things, and I think everyone else did as well. We will, with DBHDS's permission, share this presentation with the attendees. There is, he does have a glossary that follows, and also a list of the code. So the things that we talked about today, the ECO, the TDO, the last resort. So these are all, and medical clearance, all in the presentation as well. We also ask that you complete the SurveyMonkey to provide feedback on this training. And thank you so much to our speakers, Lars and Dr. Sturz. Kurt, thank you for coming in and providing your expertise as well. Thank you all so much, and have a good Friday and a good afternoon.
Thank you.
Thanks, everybody.